Okay, hey gang, so now we're gonna go over a lot of the functional tests and anatomy and special tests that we have for the ankle and lower leg. And I have Charlie here to help me. He's actually taken this class before, so he already kind of knows a lot of this stuff. So the first things that we're gonna go over is I'm just gonna point out some of the anatomy that applies to the ankle and lower leg, so that way you guys can see it more on a human instead of just on the anatomical model. So when we're looking at this kind of stuff, we've already covered the entire foot, and I'm gonna see if I can fix this lighting because it's crazy. Okay, it's maybe a little bit better. There we go. So on the foot, we covered everything, right? We talked about the metatarsals and the phalanges and the tarsals in the back, but now we need to get to the ankle. And so kind of like I talked about before, the ankle is really looking at the subtalar joint, so below the talus, and then the talocrural joint, which is above the talus, so between the talus, the tibia, and the fibula. So again, the tibia is this big lower leg bone, and the fibula is the smaller bone that's on the lateral side. And our malleoli, if you see them right here, notice the fibula hangs much lower than the tibial or the medial and lateral malleoli are. And when we're thinking about the talocrural joint, we're really coming down to the bottom of the talus and finding where, or the tibia, and finding where it meets with the talus. And the motion of the talocrural joint is dorsiflexion and plantar flexion. And then remember, at the subtalar joint, we're talking about more inversion, eversion kind of stuff. So remember when we talked about coming in and out with the foot, that's really what occurs there. So the other things to pick up on, again, are the lateral malleolus, so your lateral ankle bone here, and then the medial malleolus that sits on the inside. The other things are the ankle ligaments, and these can sometimes be difficult for people to pick up on in the beginning, but if you reference the other video where I talk about that if you know the names of the bones, then you also know the names of the ligaments. They are one and the same. And they also have directional turns in them. So again, anterior is closer to the toes, posterior is on the back side or closer to your heel. And so as we're doing this, keep in mind a lot of them are named for anterior and posterior. The other thing is, remember that we have the tibiofibular ligament. So again, they have to attach to your tibia and your fibula, and we have the inferior ones, and we also have the superior ones. So remember when we talk about them, the lateral ankle ligaments, there's only 3 of them, the LAS ligaments. They're the anterior talofibular, which is the #1 most injured ligament that we have, then the calcaneofibular, and then the posterior talofibular. So of those, you're gonna find your fibula, and then you're gonna basically come down straight off that. So your talus is just this guy right here, right at kind of where your ankle joint is. And it runs at this anterior angle that's going to go right here. And we're going to turn just a little bit. There we go. Thank you. And so it's going to run at this angle right here, and you will feel, if you come right in here, like a band of tissue. That is your ATF. If you're going to try to find your calcaneofibular ligament, your fibula comes down to a nice point at the very bottom. So you find that very far distal point, and that's what you're going to put your finger on. And then the calcaneofibular ligament runs kind of inferior and posterior. And if you run your finger like this off of it, you can kind of feel that ligament, but it comes down just like so. And then your posterior talofibular ligament, remember, you don't want to come all the way up on your tibia. You need to stay down on your talus. So that ligament, again, comes off just the opposite of your anterior and comes down onto your tibia. So it's going to be right here. So you're going to feel a little band in the back. Now you can't come up too high, because if you come up too high, now you're on your tibia. So if you can feel bone there, you're too high. Your tibiofibular ligaments are not your lateral sprain ligaments. They're not the same. They are your high ligaments. So when we talk about high ankle sprain ligaments, tibiofibular, okay? And with these, what we're going to do is we're going to find our fibula, we're going to find our tibia, and then you're going to find a band that runs higher than that. So the entire malleolus is down here, and we're going to be up here where they bind, and you should be able to feel kind of a band on the anterior. So this is the anterior inferior, because remember we have superior up here, tibiofibular ligament. So the acronym for that is AITF. And then on the back side, we have the posterior inferior tibiofibular ligament, so PITF. These guys are hurt in a completely different way, different mechanism of injury than these guys down here. These guys, so the most common for the ATF is, again, plantar flexion and inversion. So stepping on something and coming all the way in. If we're going to hurt the calcaneofibular ligament or your CF, this is straight inversion. So you are going to come straight to the inside. We don't really have plantar flexion in it. Straight to the inside. So a neutral foot. And then really the PTF, the posterior talofibular ligament, it gets hurt sometimes, but we're talking about major ankle things, and we might even have a dislocation going on. When we talk about our tibiofibular ligament, so the 4-letter acronyms, those are in the exact opposite direction. So we're getting force into dorsiflexion and external rotation, okay? So all the way up here, and these are not very common. I've already talked about the mechanism a little bit, but when this happens, what's going on is that as your foot comes up and out, it's taking these ligaments and it's spreading them out, so it's actually pushing your fibula laterally, and that's how you can tear that interosseous membrane, also known as your syndesmosis. And your syndesmosis starts all the way down here, and it travels up the length of your fibula all the way to your superior ligament, or to the head of your fibula. And you can find the head of your fibula if you come to the side of your knee, kind of, you should be able to feel a bony prominence up here. And then once you find that on either side, you're going to find the anterior superior tibiofibular ligament and the posterior superior tibiofibular ligament that are going to be on either side of that. It is not very common to hurt it so much that you hurt these, but it is 100% possible to do that. I have had athletes that have torn both of these, grade 3s, and then torn the syndesmosis all the way to the top. And then what happened was when they were weight bearing, this dude was snapping back and forth. They could actually feel their fibula snapping back and forth on their tibia. It was gross and it sounded terrible. But that happens sometimes. Then on the medial side, dropping things. Oh, I can just do it on this foot. On this side, what we're going to have then is a deltoid ligament. So the deltoid ligament, again, it's 4 ligaments, but it's shaped like a triangle or a delta. So it's in here on the inside part of your foot. And to hurt these, we typically have people go out. So remember, that's eversion. Inversion is coming in. Eversion is going out. And you can even see when he goes out how tight that skin gets and everything. Again, eversion injuries are not very common. We don't see them happen very much, but it's possible. Notice when we do this, though, it doesn't happen very much because this guy is so strong, and then also because we have this lateral malleolus that hangs down longer, and it prevents us from being able to go in that particular direction. I gotta get my dude. Okay. Did they? I don't think so. It's taped. Okay. So another thing that we haven't talked about yet are the compartments of your lower leg. And these are important for you to know because lots of different injuries. And your book talks about the different compartment syndromes, which we've talked about. So in this, we have our anterior compartment, we have our lateral compartment, and then we have 2 posterior compartments. So in the anterior compartment, we talked about that in order to dorsiflex your foot, all of these muscles are going to have to work. And so we have our anterior tibialis, we have our hallucis. Remember, anything to do with your great toe is your hallucis. And then the other 4 toes, the muscles that go to those are typically called your digitorum muscles. So we have longus and brevis, extensor and flexor. So the extensors are all going to be on this side because we're going to dorsiflex. And to extend our toes means that they're going to go up towards the ceiling. So this compartment right here is your anterior compartment. So if you guys can feel like there's the bony part on the medial side and then the lateral side's more squishy because it has the muscles there. That, where the muscles are, that is your anterior compartment. And what happens often is the anterior compartment is what gets messed up because we're forward moving people. And so that's what you slam into things. When you run into coffee table, that's not usually, by the way, enough force to give yourself compartment syndrome, but people in car accidents hit their shins like on a dashboard or something, or there's all kinds of traumatic things. If you get hit by a car and you're running or walking, that'll kind of happen. Then we also have the lateral compartment, which is just on the side, really kind of posterior or right over where your where your fibula is. And when we've talked about your fibularis, or also known as your perineal muscles, they sit in that compartment. And then on the posterior side, we have two compartments. So we have an anterior compartment, a lateral compartment, and two posteriors. And on the posterior side, we have the gastrocnemius. Can we show our gastrocnemius? Yep. So the gastrocnemius is this dude that kind of gives us our heart, right? And then right underneath that is the soleus. And we've talked before about having to be straight knee versus bent knee when we're stretching. That is our superficial compartment. So that's our posterior superficial. And then deep to those are the Tom, Dick, and Harry, the flexor tibialis posterior, the flexor hallucis longus, and then the flexor digitorum longus. Hopefully all of you guys said that was faster than me. I was just trying to go slow so that way you guys could do it. They're going to run on the posterior side, and then they all come out on the medial aspect and then run into your foot. And so in all of those compartments, we have vessels, so arteries and veins, and we also have nerves. And what happens is if we get some kind of damage to these, again, the fascia is so tight that it can only allow so much swelling to go out. So instead what happens is it starts to push in, so it starts compressing stuff and it starts squeezing down on the muscle and the nerves and the vessels, and eventually it'll cut off the nerves and the vessels and it'll basically strangle them. So that way nothing's happening, and then you can kill all the stuff in there. And so that's when they come in and they do a partial fasciectomy where they actually make a cut down whatever compartment it is that's been messed up, so that way they can relieve the pressure. It's kind of a gross surgery, but it's going to save your lower leg or whatever compartment it's in. So it's kind of one of those important things that we need to do. So getting back to the ankle and everything, very stable joint in your ankle, or the most stable joint in your ankle, is going to be your talocrural joint because of how they're locked into one another. The subtalar joint, maybe not as much, but again, that's where inversion and eversion comes from. And then the other thing to know is our talus is really wide on the front part, so anteriorly, and kind of narrow posteriorly, so kind of like your fist. Like it's really wide up front and then gets skinnier back by your wrist. So when we're talking about it being in the talocrural joint, as we try to come up into dorsiflexion, it gets jammed up because it's so wide it can't go, but we're able to do plantar flexion more because it's so skinny in the back. So that's why dorsiflexion is really limited, but plantar flexion can go a lot further, which makes your ankle motion so great in plantar flexion and your ankle so stable when you're in dorsiflexion. As far as prevention of injuries, stretching is key, and we've already talked about that you need to stretch your Achilles tendon in two ways. You need to do it with a straight knee, remember, because this is how you get your gastrocnemius, because it's a biarticular muscle. It crosses your ankle and your knee. But then we also do a bent knee because we have the soleus that lies just deep to that, and that is a uniarticular muscle. It doesn't cross the knee, it only crosses the ankle. And so that's how we're going to be able to stretch those out. We can also stretch out the anterior compartment if we were to have him like kneel down and put his foot into plantar flexion, or I can just push it down as well, and that does just as good. A lot of the other exercises, so neuromuscular control and strengthening, how we do all the different directions. So if we want to do directional stuff, I can have him push against my hand, so go down like he's hitting a gas pedal to strengthen plantar flexion. And then I can have him pull up against me into dorsiflexion to strengthen that direction. If we're going to do eversion, I would have him start with his foot all the way into the inside and then come out against me. Go ahead. So that way we can strengthen eversion, which by the way is not very strong usually and it's hard to do. And then I would do the opposite and have him push in to work on inversion. And you can do this in a lot of ways. You can do it manually. You can use towels. We could wrap where my hands were, put like a TheraBand, so one of those stretchy dudes to do it. Tons and tons of ways to do it. Balancing on two legs, single leg, tandem stance. There's all different kinds of things that we can do to try to strengthen and to move people around. So when we talk about evaluations, there's a lot of things to think about. Number one, their past history. The mechanism of injury, guys, is going to be huge. Was it a chronic or acute thing, and how did they fall? Did their ankle go to the inside? Did it go up and out? Did they fall straight over it? Like, what happened? And you're going to really need to think about the mechanism, because that's going to help give you a clue as to potentially what happened. Don't just ask if it hurt, ask where it hurt. So it's really important to say, can you take one finger and point exactly where it is? Because just because you think you know what the injury was doesn't mean that you do. So remember, in the foot, we talked about a Jones fracture and how they're going to have pain on that lateral aspect of their foot way down here. And the mechanism for that is identical to the mechanism for a lateral ankle sprain. Remember, we talked about how it's plantar flexion and inversion. So plantar flexion and inversion can get our anterior talofibular ligament and our calcaneofibular ligament, but it can also give us a Jones fracture. So if you don't ask them to point and they just say it hurts on the outside of my foot or ankle, you can assume it's one or the other. But if you ask them to point, you're going to know for sure if you should be looking for a fracture or if you should be looking for a sprained ligament. Or potentially you could also have an avulsion fracture of the fibula. So it's really important to ask them to point. Or maybe their pain is on the inside, even though it was an inversion injury. So always ask them to point to where it really, really hurts. Also, crepitus or sounds. Does it sound funny? Does it feel funny? Does it feel grindy? Does it feel like it's giving way? All those things are going to be really important for you to understand what's going on. Swelling. It might not be swollen when they come to see you, but it could be swollen prior to that. Maybe it took them a week or so to get to come see you. So think about what's going on, and then have they ever had something like this before, and what did they do to make it work? And then also, have they done anything for it since they came to see you? Again, it might not have just happened. It might have been there for a little bit. So these are things to think about. From observation stuff, again, you want to look at when they came in. Were they walking on it? Were they limping? Would they not put any weight on it? Does it look like they're evenly distributing everything? Does it look like they have a leg length discrepancy maybe? Now, the one thing I want to show you, pop up for me, is genu varum and genu valgum. And this is really something that we're going to focus a lot more on when we talk about the knee. But when we talk about genu always means knees, okay? And for knees, what we're going to talk about is genu varum and genu valgum are the two directions. And so when we have genu valgum, remember we talked about that there is a pronated foot, which means they kind of walk on the inside part of their foot. And when they do that, it's going to make them become more knock-kneed. So they're going to come in and they're going to have that kind of angle that's going to go like this. If they are pes cavus, meaning that they're going to be more on the outside part of their foot, it's going to make them round out, and they're going to be a lot more bow-legged. So they're going to be kind of like the cowboy that just got off the horse kind of thing. So when they do that, they're going to come out, and it's going to kind of round out and stretch this part and then compress this part together. If they have these things, it can really change what's going on in their lower leg. So these are things to really think about and understand. And we'll talk a lot more about this when we get to the knee, but I wanted to make sure that I brought that up. Again, difficulty with walking, swelling, pain. Think about all the signs of inflammation, so all the redness, tenderness, swelling, that kind of stuff. Do they look like they're in pain? If you look at their face and they're making pain faces or uncomfortable faces, even though they say that it doesn't hurt, that's stuff to pay attention to. And when you're going to do tests and touch and all that kind of stuff, those are things to think about. And then motion. So we've talked before about the ankle motion. Is it normal? And you always, again, every time you do anything, comparing tests, you're going to do their good side first and then their bad side, because you need to see what's normal for them, but also that helps them trust you because they know what's about to happen instead of just being scared and guessing how bad you're going to hurt them. Some tests kind of are uncomfortable anyway, and other tests aren't, but people need to know that it's going to be okay. So from the palpation standpoints, we've already kind of gone over most of the big stuff. Again, just know where your Achilles tendon is and the gastrocnemius, and we've already kind of talked about the bones and the malleoli and everything, so just make sure that you understand that stuff. And now we're going to hop to the special tests. And the first one we're going to do, and I'm going to kind of do them out of order a little bit, is the Thompson Test. And this is the test that we use to assess for Achilles tendon tears. So again, if we have a torn Achilles tendon, that means that our gastrocnemius and the soleus that runs just deep to that, may not be attached to the calcaneus anymore, which is going to be problematic for our patient. And again, they might feel like they just got hit or kicked or shot someplace like down low in their calf. And remember, most tears are within 2 to 6 centimeters of the insertion down here on the calcaneus. Super easy test to do. All you're going to do, because when these muscles contract, what happens? You go into plantar flexion. So you're going to mimic what these muscles should be doing by contracting, and you're just going to squeeze their calf. And can you see how his ankle is moving into plantar flexion like that real nice? That is a normal response. That means that his Achilles tendon is intact. Now, if instead, I don't know if you can do this, but try. If I squeeze it and it doesn't move, can you hold it there? Yeah. And it just keeps hanging down and there's no plantar flexion going on, then that's a pretty good sign that they probably tore their Achilles tendon. It's really hard to fight it though, because when you squeeze it, these are pretty strong muscles. And so even though he's trying, he was still moving a little bit into plantar flexion. So it gives you an idea like how strong these muscles are and how strong this is. Like, it's a pretty big deal. But again, you would always do it on the good side first and then do it again on the potentially injured side. And they might still have a little bit of motion if they have a torn Achilles, but there's a strong probability, or it shouldn't move as much as their uninjured side. Go ahead and flip over. So then we're going to go to the fracture tests, and these are very similar to the tests that we had for the foot, and when we have the percussion test and the compression test. So for the percussion test, it can also be called the pound test. Can you actually move up just a titch? Awesome. You're just going to take your fist and you're going to hit it with the side of it. Don't punch it, hit it with the side of it. And you're just going to kind of pull them up into a little bit of dorsiflexion and then just hit the bottom part of their foot, which is going to cause vibration. And if they have fractures, if it's in their calcaneus, they're really going to know it because you just punched their calcaneus. But really, when you're doing this, you're looking for them to complain of pain in their tibia and their fibula. You can also do this test if they do have some kind of potential foot fracture issue, but mostly we're looking for issues that are going to be going on here in the tibia and the fibula. The other test that you can do is called the compression test, and you're going to interlace your fingers together, and then you're going to wrap them around the tibia like so, and you want to make sure that your one hand, so right here, this fat pad, it's not really fat pad, it's all muscle, but is right running down the fibula on the side, and then the other one is going to be running down the medial aspect of the tibia with your fingers interlaced over the top. And then you're going to take it and you're going to squeeze and squeeze, and you're going to slowly work down. But now you're only going to work downwards if they're complaining of pain that's distal. If they're complaining of proximal pain, you would start down at their ankle and work up as you're squeezing these together. And what you're looking for is for them to complain of crepitus or popping or pain. Really just pain is what they're going to say. And then you're going to see if you can feel crepitus, because what can happen, especially if it's a fibular fracture, really this is a fibular test, is that you're going to feel the ends of the fibula go. Yep. And so it might normally be lined up, but as you squeeze it, it can actually make those ends shift. And let me tell you, when it's positive, it is very positive, and there's no doubt about it. Now, people could have a stress fracture and not have that be positive, but even still, I feel like even for stress fractures, people often still complain of those issues. And this can also work for avulsion fractures down here on the lateral malleolus, so distal fibular fractures. And sometimes those can be really difficult to diagnose, so sometimes you need to send them for x-rays to figure out if it's a lateral ankle sprain or if it's actually a distal fibular fracture, okay?